Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Well, welcome everybody. You're listening to special conference coverage from the 2026 RAPIDS Conference. I'm Eileen Cheever, Dermatology PA, and with me I have Dr. Heather Woolery-Lloyd. Thank you so much for joining us. We're so excited to have you.
Thank you. I'm excited to be here.
So we're really excited to talk to you about a number of the lectures that you gave today at the conference. And that first lecture that you did surrounded immunology and emerging therapies with vitiligo and melasma. And I found your commentary about educating patients about melasma really powerful because we know that melasma can be challenging, from the myths, the truths, the misconceptions. How about some practical pearls when you're counseling your patients about the condition?
So I sometimes call this the melasma dialogue because I feel like just as important as your treatment. So I first ask patients, do you know what you have? Do you understand it's a chronic condition? So I want them to understand that we're going to work together as a team to get them better, but it is more of a long-term process than a quick fix process. Then, after I kind of establish where they are and how much they understand about melasma, I talk to them about sun block and sun avoidance. So, sun protection and sun avoidance. So, I will really emphasize that. That's at the beginning. I don't wait until I give them all of their therapies. I say at the beginning, the most important thing is that you wear sun protection every day, find a sunscreen that you love and wear it every single day. If you're outside, make sure you're wearing wide brimmed hat. So I really go into details on how they can avoid the sun because I explain to them that if I get you 100% better, if you walk outside for 10 minutes without sunscreen or sun protection, the melasma comes right back.
It's all it
Literally,
takes.
in 24 hours, it'll be right back. So that I think is really important. And if you don't have the discussion with the patient, they're less likely to get good results. And so I focus on that. And then, of course, I give them their treatment plan. When I'm using hydroquinone, I will tell them it's a great quick fix and it works great, but the work begins the day you stop the hydroquinone. And in my practice, I usually use it for 4 to 6 weeks. So after 4 to 6 weeks, you're going to look great. You're going to think, oh my gosh, this is a miracle. My skin is so much better. But we can't use it forever. It's not a long term treatment. It really is, for me, a quick fix. And then I try to maintain with other topicals. And so I spend a lot of time educating the patients, giving them lots of information so they have the tools to get the best success.
Do you really emphasize the importance of that? The term you use, which I love, is that hydroquinone holiday, and why it
Yes.
is important. You would think
Yes.
maybe with patients that are so eager to get this condition better, they would say, surely more hydroquinone
Yes.
must be better.
Yes.
Tell me about kind of the nuance surrounding that.
So I do tell them it's really important to do a hydroquinone holiday. And I tell them the words I actually use is like, you want to keep it in your back pocket for when you need it. So it's one of those things where if you're on hydroquinone continuously and then you happen to be outside for a lot and your melasma flares, or you go on a vacation to Hawaii and your melasma flares, if you're already on hydroquinone, you don't have a tool to pull out that you need. So I explain it to my patients that way. And I also tell them that it stops working eventually, like if you're just on it continuously. Another little clinical pearl is I never give refills ever. I mean, I would say maybe once a year, if I really trust a patient and they live outside the country, I might give a refill on hydroquinone. But I really want to be in control of how much hydroquinone the patient has to avoid this issue where they're using it continuously for months and months and months.
It's a great way to have that system of checks and balances where you
Yes.
know how many
Yes.
refills that you did or didn't give the patient. How about the approach maybe outside the box? It's definitely not a one size fits all approach. Any kind of comments or anything you can tell the listeners about new things in the cosmeceutical department or world for treating melasma?
Luckily, there are a lot of really new things that have come out for us in the US in the last few years. So one of them is thiamidol. Thiamidol works by inhibiting human tyrosinase. So most of the tyrosinase inhibitors that we've heard of that we typically use, including hydroquinone, actually have been tested on mushroom tyrosinase because mushrooms make their own melanin, but human tyrosinase is actually completely different. And so thiamidol is a potent inhibitor of human tyrosinase, and that is available in a serum. It's also included in the day and the night cream. So I often give that full regimen, the serum in the day in the morning and the serum in the night. And then there's another great new ingredient called 2-MNG that is also a new ingredient with a different mechanism. So it works by binding melanin precursors, and it leads to a reduction in both pheomelanin and eumelanin. And that 2-MNG product also comes in a serum, very commercially available, widely available, affordable price point, and it's also included in the day cream with an SPF. So those are two that are new, relatively new to us here in the US, and work very, very well as alternatives to hydroquinone. And then there are some others that were just recently published. So fresh off the press, published in March of this year, is malisesin. So malisesin is something that is a metabolite that we see in our patients with tinea versicolor. You know how their skin gets lighter.
Sure.
So it's been isolated and it works for pigmentation. So in a study comparing it to hydroquinone, it was not inferior. And then there is one more new one, and it's new in the sense for pigment, but not new to us. It's fluornithine, 13%. So fluornithine was used to treat unwanted facial hair, and it's been available for, over a decade, I think. It's been available ever since I was a resident. And interestingly, it can help with pigment. And in a study comparing it to hydroquinone, again, it was not inferior. So there are some new agents. Those are the two, the fluornithine and the malisesin are kind of hot off the press, those publications. And then thiamidol and 2-MNG we've known about for the last couple years, but I've really been using them so much in my practice.
Anything that our learners should know about maybe adverse events to look out for those new products? We know pretty much the safety profile established with hydroquinone. Anything we
Yes.
should be on the lookout for?
So the great news, at least the ones I'm familiar with that I personally have been using, the thiamidol and the 2-MMG have great safety profiles. So I haven't really seen any irritation, and they can be used long term. That's why they're perfect for melasma because they're great for long term maintenance. The newer ones, the fluornithine and the malisesin, I haven't had a chance to personally use them for melasma, so I can't tell you from my clinical experience. But in the clinical trials, they were well tolerated. So the great news is that you can use these long term for a condition that is a chronic condition. So someone who has melasma in her early 30s, she's going to have it for, 10 years or more before it kind of goes away on its own. That's another part of my melasma dialogue that I love to tell patients is that melasma is a condition seen in younger people, 30s, 40s, early 50s, but in general it does go away because that hormonal drive does dissipate with age. So we don't see that many 80-year-olds walking around with the melasma. So that does make patients feel a little bit better. I always say we don't have to wait, 30 years for it to
Right.
get better. I'm going to get you better now, but know that you won't have this forever.
And then wrapping up talking about melasma, tell me about the information you shared about botulinum toxin in terms of
Yes.
treating melasma.
Yes. So this is a new study, two or three new studies that were published in the last year, hot off the press. And in the studies, they use botulinum toxin into the patches of melasma, and it was an intradermal treatment. And it's very interesting to me because it's actually repeated. So one of the studies I talked about today was where the full face got triple combination products to the full face, but then half of the face in the melasma affected areas got intradermal botulinum toxin just into the melasma affected areas, intradermal. And they did that intradermal toxin treatment at baseline and at week 12. Then at week 12, they stopped the triple combination product, which was being used on the full face. And of course, when you stop the Kligman formula, there's always a rebound. So you always are going to see an increase in melasma the second you stop. So on the side of the face that didn't get the botulinum toxin, you saw an increase in their melasma once that triple combination was stopped at 12 weeks. But on the side of the face that was treated twice with the botulinum toxin, you actually saw it continue to get better over time, which you would never expect after stopping a triple combination cream. So this is something that's very exciting to me because we're very familiar with botulinum toxin, so it's not like something that we don't have a lot of experience with. And I think it sounds like from the studies, I haven't had a chance to use it in my practice, that it might be helpful to kind of maintain people after they've stopped their hydroquinone triple combination product.
And they were injecting it
They
subcutaneously?
intradermal, so
They went
very
intradermal,
superficial,
okay.
like little
Yep,
blebs
yeah,
into the
fantastic,
patches.
wonderful. Well, let's switch over to the other portion of your talk and speaking about vitiligo. And when you are making that diagnosis of vitiligo, making sure that you have the whole picture, really understanding the patient from a medical point of view is important. Tell me about the role of thyroid testing and making sure you order the correct and appropriate thyroid tests.
So I like to order not only an ANA is sometimes helpful, and just to screen for any other autoimmune conditions, but TSH and thyroid autoantibodies. So normally we would think of TSH as the screening test for thyroid disease, for autoimmune thyroid disease. But what we know is that people who have vitiligo have an increased risk of autoimmune thyroid disease. So even though their TSH is normal and they're euthyroid, they might have thyroid autoantibodies that are positive. And I trained at a program where we saw a lot of pediatric patients with vitiligo. So I think this is very important in your pediatric population in particular, because it would be helpful for the pediatrician to know that all of this child is euthyroid, they do have thyroid autoantibodies, so something to kind of to keep in the back of your head. And the reason why this is important is because people who are euthyroid but have thyroid autoantibodies have a higher risk of developing autoimmune thyroid disease in the future than if you're euthyroid and don't have thyroid autoantibodies. So it is predictive. You're not 100% going to get autoimmune thyroid disease, but you could get it. So it's good to know. So for my screening test, ANA, TSH, and the thyroid autoantibodies.
Just so you really have that whole picture and
Yes.
you're not missing
And
anything.
especially for kids because it's helpful for the pediatrician to
Right,
know.
right, okay. And then talking about getting into treatment, you gave a really nice clinical pearl from the podium about UV exposure, just even
Yes.
being outside. A
Yes.
quick little kinda tip. Tell us about
Yes.
that.
So I like to tell my patients 10 minutes of sunlight a day with sunscreen. I'm not telling them to go out without sunscreen, but I do think if they're not doing light therapy, we use all of these anti-inflammatories to suppress that autoimmune driver of vitiligo, but they do need a little kick. Their melanocytes need a little kick to jump start again and start creating pigment again. I practice in Miami, so I have a lot of help from the sun here, but I do think 10 minutes of sunlight, sit outside at lunchtime for 10 minutes or walk outside for 10 minutes in the morning, just gives the melanocytes a little bit of a kick if the patient is not getting narrowband UVB therapy.
Okay. Helpful tip, and
Yes.
practical. Tell us about procedures for vitiligo. You'd spoken about a cell suspension transfer, which was really fascinating. I think our listeners would love to hear about it.
Yes. So the cell suspension transfer is FDA approved, although it's not currently available. And I'll explain how it works. So basically, you take a small piece of skin around the size of a postage stamp. It comes from behind the ear. It's a split thickness graft. And then the machine, which is one per patient, so it comes a machine for the patient or the device, processes that piece of skin. So you get basically a liquid spray that contains keratinocytes and melanocytes. And then the vitiligo affected skin is usually abraded, or in the clinical studies, there was a laser that was used to kind of alter the stratum corneum so there would be better absorption. So you would use like some sort of ablative laser. And then the cell suspension is sprayed on or applied to the wound and where the vitiligo is, and it's wrapped. And then over time, you see repigmentation. So in the clinical studies, they did see 36% of patients saw at least 80% repigmentation of the treated area. And both the patients and the investigators in the trial felt that the treatments were successful, a high percentage. So it's something that I think is useful. It might be useful for a stubborn patch of vitiligo. I'm very excited about it. It's not currently available, but the other great thing about this new treatment is that one little centimeter that's postage stamp behind the ear that you're getting a split thickness graft can treat areas up to 80 times more of that. So you can treat 80 postal stamps, that size. So it's a 1 to 80, like, I guess, ratio. Whereas the other procedures that we use for vitiligo, like suction blisters or things like that, you remove a suction blister and you apply it. It's 1
One
to
to one.
1.
Right.
So this allows you to treat a larger area of vitiligo, which I think is very exciting with just a little postage stamp split thickness graft from behind the ear.
More options for treating and getting these patients the improvement, hopefully, that they need and they deserve.
Yes.
Well, let's wrap up today's conversation by talking about the amazing panel that you participated in while here at Rapids. And you had talked about a mid-60s-year-old female with melasma. And in your case, you had mentioned the potential role of antioxidants in treating patients with melasma. Tell us about that.
So I do use oral antioxidants, and I primarily use polypodium leucotose leukotomas, but many have been described, including pycnogenol, pine bark extract. So we do know that when these oral antioxidants are taken, they're giving us a little bit of extra photoprotection. I personally did a double-blind placebo-controlled trial many years ago where half of the patients got polypodium leukotomas, half of the patients got a placebo pill, and we were blinded. And the patients who got, and just sunscreen, so it was sunscreen and polypodium leukotomas, sunscreen, and a placebo pill. And in this study, the patients who got the polypodium leukotomas had improvement in statistically significant improvement in their melasma, their quality of life scores, everything. So we definitely know that oral antioxidants are helpful with melasma. I use polypodium leukotomas the most, but we're going to see more coming. So this is an area for you to think about when your patient is resistant. And melasma is one of our more challenging conditions. So this is something to think about for those patients.
Easily accessible. Patients
Yes.
can get these, relatively safe, of
Yes.
course, with some promising
Yes,
results.
and people are very interested in supplements in general nowadays.
Sure.
So there's lots of data to support these types of supplements for melasma.
Talking about medications and supplements, are you double checking your patient's medication list or what they're using? It's a great time in medicine for folks that are going through different conditions.
Yes.
Talking about estrogen, phytoestrogens, essential oils, watching out
Yes.
for these hidden triggers that patients might not even
Yes.
think about with melasma.
So I have many, many melasma patients who develop melasma perimenopausal or postmenopausal with hormone replacement therapy. So and there are many different ways you can do hormone replacement. So even with topical estrogen, I worry a little bit about melasma. So something for you to think about. Maybe if the person is using intravaginal estrogen, they might not realize that that could be a trigger for their melasma. Obviously, oral contraceptives are a well-known one. So I do ask about that. And then a lot of our patients, especially our patients of color, are using a lot of topical oils, maybe on the scalp or on the skin. And some of these oils have phytoestrogen. So in one of my patients, she was using lavender oil, which we know actually has a lot of phytoestrogens and has been reported in one case report, but to cause gynecomastia in young boys. So there's quite a bit of estrogen in things like lavender oil and tea tree oil. So it's important to keep that in the back of your head if you have a challenging patient that you've never asked, wonder why is this melasma so persistent in a 60-year-old, right? Late 60s, early 70s. Think about things that could be driving that melasma.
Where they were doing so well, and now they come back and see you and
Yes,
say, "I don't understand why I'm not doing so well."
right.
And lo and behold, maybe they forgot to tell you that since
Yes,
you saw them last, they've introduced one of these things.
exactly.
Well, thanks for spending some time with us today. Dr. Heather Woolery-Lloyd joining us for a special conference coverage here at Rapid. So thanks so much.
Thank you.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.